Now, I would like to invite Dr. Sajala once again to talk about the practical aspects of performing intelligent auscultation by graphic Doppler. Welcome, ma'am.
Yeah, thank you, Pallavi. I'll just share my screen. Hello, is my screen visible?
Yes.
Yes. Okay. A good afternoon, a good evening to everyone. And I would be today discussing the care bundle, intelligent intermittent auscultation using a graphic Doppler, one of the care bundles of the PREVENT study. Now, as we all know, it was in the early 1600s that hearing the fetal heart sounds was tied to fetal well-being. But it took the introduction of the Pinard fetoscope in 1876, by which time we could auscultate the fetal hearts and find out about fetal well-being. We then moved to the stethoscope, then we had the handheld Doppler, and then finally the CTG machine where we could get a graph of the fetal hearts along with the uterine contractions. And we thought we were very much enabled in monitoring the fetus. But recent evidence shows that the CTG, the introduction of continuous cardiotocography, it actually probably increased the rates of cesarean section and instrumental delivery with not much of a concomitant reduction in neonatal mortality or cerebral palsy. There was a small absolute reduction in the neonatal seizures, but it did not show any long-term effects. So much so that now in 2018, even earlier by the FIGO in 2015, the recommendation is that continuous cardiotocography is not recommended for assessment of fetal well-being in healthy pregnant women who are undergoing spontaneous labor. And they have actually recommended intermittent fetal heart rate auscultation during labor with a Doppler ultrasound device or a Pinard fetal stethoscope for healthy pregnant women in labor. So when we use the handheld Doppler, which is so you can use it in your hand. It's a very easy equipment to use. And when in the graphic Doppler, you can get a display of the fetal heart rate along as per the fetal, as according to the time. Then we seem to have the best of both worlds, where you can get a graph without the need for cumbersome equipment, without the need for getting the woman who is attached to the monitor and then restricting her mobility of the parturient. So it looks like with the graphic Doppler, we have the best of both worlds. So in the next 10 or 15 minutes, I would like to just take you through what exactly is intelligent intermittent auscultation, why we should do it with a graphic Doppler, for whom we can use it, how do we do it, and how do we plan management depending on our results. So intelligent intermittent auscultation is a recommended method of monitoring the heart rates of babies in the womb, where pregnant women are considered at low risk of fetal hypoxia during labor. And this monitoring of the fetal heart rate by intelligent intermittent auscultation we do in the PREVENT study by using the graphic Dopplers. Now, many of us are familiar with the handheld Doppler, which will tell us what the fetal heart rate is at any given time. Now, we look at the numbers, we look at the commonest appearing number, and we consider that as a fetal heart rate. But often, because there is no display, we might have an erroneously high or a low fetal heart rate, which makes it difficult for us to actually assess accelerations and decelerations. But with the graphic Doppler, you can see that there is a display, there is a graph of the fetal heart rate at time. We can see a trace for around 10 minutes at a time, and we can easily identify what is the basal fetal heart rate, and we can see the accelerations with the fetal movements. So this helps us in identifying what is the condition, identifying better actually what is the condition of the fetus in utero. So how do we go about it? Now, as the patient is admitted in the labor room, we first have to have a clinical assessment of the woman, and we do an appropriate risk categorization. Remember, as we said, that this is useful, this is actually recommended for low-risk women who do not have any complications. So that is the first step that we do. We look at the admission risk factors. Does the mother have any risk factor, like previous cesarean section, preeclampsia, post-term pregnancy, prolonged membrane rupture? Is the labor induced with oxytocin? Is there an antepartum bleed? Are there other maternal diseases? In all these cases, she would be a high-risk mother. Similarly, the unborn baby can have risk factors like growth restriction or macrosomia, prematurity, post-term, oligamnios, some abnormal Doppler on the antenatal surveillance. Could be a multiple pregnancy or a meconium stain like an abnormal presentation, and of course, intrauterine infection. If there's evidence of any of these, this is a high-risk woman and she would probably do better escalated to electronic fetal monitoring if available. Now, once you have done the risk assessment at admission, you must auscultate the fetal hearts with the graphic Doppler for around 10 minutes and check to see what is a baseline rate, note that down, and look for an acceleration with fetal movement. Now, why are accelerations important? Now, you can see the study in the 1971 studies, which tells us that with a normal fetal heart rate and the presence of acceleration, most of these babies, or most none of these babies actually have shown acidosis. All these babies are actually doing very well with a normal pH. So that is the importance of determining an acceleration at admission. Then we know that this baby is at low risk for hypoxia and can be continued with intelligent intermittent auscultation. Now, once she goes into labor, we will auscultate her every 30 to 45 minutes for 3 minutes. And in the second stage, every 5 to 10 minutes after each contraction. How exactly we go about it, we'll be seeing later. Now, if there is any problem or if any additional risk factors develop during labor, like for example, she develops a fresh episode of vaginal bleeding, or the mother develops fever, there is the LICA becomes meconium stained, or she's fully dilated and you're planning a difficult instrument delivery, or there are some acute sentinel events like a cord prolapse, abruption, or a rupture, which actually occurs in less than 5% women. And if we have oxytocin augmentation. As we've heard earlier in a lot of the discussion before, that most often we see that labor progresses on its own without recourse to oxytocin, and oxytocin does have its ill effects. So in indicated cases, if we're using oxytocin augmentation, that is an additional risk factor which develops during labor, and electronic fetal heart rate monitoring would be warranted. Also, if the intermittent auscultation detects some red flag signs like an abnormal baseline rate, or the presence of decelerations, then this would be a reason to escalate the mother to electronic fetal heart rate monitoring. So now we know that we have the low-risk women who have a normal baseline rate and presence of accelerations at admission. When she goes into labor, how do you go about monitoring her with the graphic Doppler? First and foremost, you must explain the procedure to the mother and to the companion. This is important because we need to take the trace soon after contraction, and that is a time when the mother actually has maximum distress. She's unlikely to be happy having you putting the Doppler probe onto her abdomen at that time. There would be some amount of discomfort. So this has to be explained properly to the mother and the companion. And each time you put in the transducer, you may have to keep it there for 3 to 5 minutes. So she has to be supportive. Now, once you've done that, you localize the fetal heart with the Doppler. We know that it's heard loudest at the level of the anterior shoulder, and it sounds like a galloping horse. It's important to know this because you must differentiate it from the mother's radial pulse, because the rate will tell you a difference apart from the whooshing sound of the maternal or the fetal vessels. So once you've localized the fetal heart with a Doppler, keep one hand over the tummy to check for contraction. It is important that we get a tracing which is soon after a contraction. Now, if the mother pushes away due to pain, which is quite natural that she do so, please reassure her, and we need to seek the help of the birth companion. And definitely, we should not be scolding her. A proper explanation of the reason why we need to check her at this particular time, because that is the time when the baby is likely to suffer maximum hypoxia, would definitely ensure that she cooperates with us. Now we repeat this auscultation every 15 to 30 minutes in the first stage of labor if everything is fine. And once she goes into the second stage of labor, you would repeat it every 5 to 10 minutes and after each contraction. If it continues to be normal, you can continue with intelligent intermittent auscultation. However, if any abnormality is detected, then what we must do is continue with the auscultation for around 2 or 3 more contractions. And if the abnormality persists, then we need to escalate to the CTG monitor and alert the senior personnel on duty and plan the management options that we have. Now let us take a look at some examples of the graphic Doppler trace. Now this is a lady. We can see that we have a baseline rate of around 145 per minute, 145 beats per minute. And you can see a couple of accelerations. There are no decelerations. Now, one disadvantage of this trace is that we have no idea as of now as to what is the state of the uterine contractions during that time. However, when we are using it in real time, using the Doppler, it also promotes an interaction between the healthcare worker and the mother, as opposed to having the monitor attached, and then you have the paper spewing, you have the machine spewing the paper, which can be viewed at any time afterwards. So using a graphic Doppler to actually look at the fetal hearts improves the interaction with the caregiver and definitely helps us also to see other maternal parameters at that time. So when we start auscultation soon after contraction, you get to know if there are any decelerations. If there are no decelerations, you have to continue the auscultation for another 3 to 5 minutes, because we need to get the period between 2 contractions where we can actually find out what is a baseline rate. One of the important signs that we see as a harbinger of hypoxia in the fetus is an increase in the baseline rate. So after contraction, you listen, you look for any deceleration, you wait for 3 to 4 minutes so that you get a tracing in between 2 contractions. And once you find that there are no decelerations, you can stop and get back to her after another 30 minutes. Now, this is another tracing, which apparently looks normal, but if you look at it, the baseline is a little above 160. It could be a 165 to 170. However, there are no decelerations, and we have continued auscultating for some time to look for any onset of deceleration. So there are no other alerts. And if the uterine contractions, when you take it in real time along with the uterine contractions, then you know that probably this is a normal trace. Now, once you record a normal trace, what are we supposed to do? As Jyoti and Bhamta explained earlier, we have to fill in the labor care guide. Section 3 of the labor care guide has areas where you will record the baseline fetal heart rate as a single counted number of beats in a minute. And if the beat is less than 110 or more than 160, then it is an alert. What do you do in such a case? You ask the woman to turn on her left side, alert a senior care provider, and then you follow the clinical guidelines. If the fetal heart rate comes back to normal, then you can continue monitoring for another 2 or 3 contractions. If everything is fine, you revert back to intelligent intermittent auscultation. If not, if it continues to be on an alert, then you may have to escalate to electronic fetal monitoring. At the end of the section, in the labor care guide, you also need to fill section 7. Of course, you would have seen all the other aspects as we've just discussed in the previous talk. And you will have to put in your assessment, and the plan also we will need to enter depending on what our observations are. Now, beat-to-beat variability, we don't usually it is difficult to identify the beat-to-beat variability or the baseline variability by auscultation. So that is not really taken into consideration. But if the accelerations are present, then it is likely that the beat-to-beat variability is also normal. Now, let us look at some other examples of the Doppler trace. Now, here you can see that the baseline is around 140. There is an acceleration, but you find a small deceleration creeping up. It's just up to 120. It seems to pick up fast. Now, because you're doing it in real time, you know when the uterine contraction has started. And if it's an early deceleration, then you will mark it as E in the labor care guide, and that is not an alert. But if it is coming soon after a contraction, then we need to continue monitoring this for some more time and see how it develops. So if the decelerations persist, or if you have repetitive decelerations which are proceeding on, and if you have an increase in the baseline rate, which is not actually seen in this graph, then you probably need to escalate to electronic fetal heart rate monitoring. This is another trace which shows the presence of a deceleration. And when we mark it, depending on whether it's a late variable or a late deceleration, it will show an alert on the graph only if it's a late deceleration. As seen earlier in the importance of late decelerations, if you have late and prolonged repetitive deceleration, then it's definitely a red flag sign and it could indicate that the baby is hypoxic. There's another trace of showing a deceleration. So when you see these decelerations, as I said earlier, you need to record the presence using N for no decelerations, E for early, L for late, and V for variable deceleration. And it's only the late deceleration that will mark a red flag or a red alert. And if you find a deceleration, again, it's the same procedure that you have to follow. Ask the woman to turn to her left side, continue performing the auscultation, see whether it persists over the next couple of contractions. If not, we can continue with the intelligent auscultation with the graphic doppler. But if the decelerations repeat, then definitely she will have to be switched over to electronic fetal monitoring. So now when do we escalate? Escalate means when do we convert from graphic Doppler to electronic fetal heart rate monitoring? Definitely the presence of decelerations is an important alert, and we will need to change over to electronic monitoring. Similarly, an increase in baseline rate like you find that there are decelerations, and then after a couple of contractions, you find that the baseline rate is increasing. That could signify that the baby could be going in for hypoxia. So that's another reason to escalate. Now, again, it is said that accelerations which occur just after contraction is unlikely to be due to fetal movements. We need to continue for a few more contractions. And if it persists, maybe that's a reason to just move the patient to the electronic monitor, check whether everything is fine. If it is fine, you can revert back to intermittent auscultation. Again, tachysystole, if you are monitoring the patient and you find that she has more than 5 contractions per 10 minutes, we probably need to find out what is the cause. And we need to take measures to see whether she needs a uterine tocolytic. And any other development of any other additional risk factors in labor also would be a reason to escalate. And what do we mean by escalation? Basically, we need to alert the senior personnel on duty so that they can come and take an informed decision. We need to switch to continuous electronic monitoring, get a graph over a period of time and see how the baby progresses. We need to identify any risk factors that would have developed. You have to do a PV. We need to see whether there is a cord prolapse or there is a bleeding and abruption has developed. Are there any identifiable causes? If any, definitely we need to institute corrective measures. If we have the facilities and the electronic monitor, the CTG shows a persistence of decelerations, we might do ancillary tests like scalp blood sampling, and accordingly we would plan the management, also taking into consideration what stage or phase of labor the parturient is in. So my take-home messages would be that intermittent auscultation helps in timely identification of fetuses with hypoxia and acidosis. Done properly, there is no reason why we should miss out on a fetus which is developing a hypoxia and acidosis. And if we do that, we can take appropriate actions before injury actually occurs. And using intermittent auscultation will help avoid unnecessary interventions, as is the case with CTG. When the patient is on a CTG monitor and you see repetitive early or variable decelerations, it's sometimes a little difficult for us to give a little more time, although we know that possibly the baby is fine, especially when we do not have recourse to ancillary tests like scalp blood sampling. And for intermittent auscultation, the graphic Doppler is a very simple and effective tool. It is handy, and used correctly, it definitely has potential to improve neonatal outcomes. I would like to thank Professor Arul Kumaran sir for allowing me to use a lot of his presentation and for all the inputs. Thank you, sir. And this is a link to to sir's video on intelligent intermittent auscultation, which definitely I would encourage everyone to watch. Thank you, sir. And I'd also like to thank Minnie ma'am from the head of HOD Gynecology, Government Medical College, Kozhikode, and our superintendent, Dr. Sri Kumar, who have extended all their support for this program and the study. Thank you.
Thank you so much, ma'am, for that presentation. Can I request everyone to please post your questions on chat, or you can directly ask them.
Thank you for the excellent talk. Excellent.
Thank you, sir. Sir, about the tachycardia overshoot that is coming after the contractions, would you just like to tell us a little more?
Yeah, thank you. So if there is a variable deceleration and the baby is finding it difficult to tolerate cord compression, it responds with tachycardia when it recovers. So it goes down and then comes up and takes a little bit more long time to settle down. So in that case, as you suggested, it's better to wait for the next contraction and monitor the fetus so that the next one will show the deceleration coming, and then it's the return arm goes beyond. Then you know it is a problem and we need to monitor that fetus carefully. So it's one of those what we call overshoot. So it's important to listen, and if it doesn't return to baseline but overshoots, then better to continue for the next contraction and then decide whether she needs continuous monitoring or not.
Yes.
Thank you.
If there are no more questions, I would also like to thank the Prevent team and Dr. Sudhin for all the help with the presentation.
So Dr. Rani Bashir had asked if there are recordings available. So ma'am, we have it's being live streamed now on YouTube. So I can share the link with you. So it will be available online. So if there are no further questions, we can take a short break. Meanwhile, if you have any questions, please feel free to post them on chat. So once we start a Q&A session, we can discuss that. So we'll take a quick 5-minute break and we'll be back. So I request all of you not to log off, but please leave your microphones and videos off. So maybe we can reconvene in another 8 minutes, I think. So that's 5 p.m. India time. Thank you.
Thank you.
Welcome back, everyone. May I request everyone to switch on their video for just a few seconds, just to make sure everybody are back. Thank you. Thank you so much. So next, I would like to invite Dr. Vaishali